Hi, everyone. I'm very excited to be here today with Dr. Kerwin. Welcome from New York City. There's going to be a little bit of a construction noise in the background, but that shouldn't stop us from having a good hour together. I just wanted to start this conversation by presenting a few slides on CurePSP and the work we do in research. We'll present around 40 minutes, and then we'll have ample time to answer a question from the audience, and we're looking forward to this conversation. Thank you, Dr. Kerwin, for joining us for this hour. So before I start, I wanted to give you a little bit of information on who we are at CurePSP. We are a nonprofit organization founded in 1990, and we're New York-based with 10 employees, and we focus on prime of life neurodegenerative disorder, including PSP, CBD, MSA, and other diseases. And our vision is the world free of PSP, CBD, and MSA, and related brain disease. So I just wanted to give a shout out to one of our events that are celebrating the fact that CurePSP this year turns 30. So on December 7th, there will be a virtual gala, and I encourage everyone to join, and the slides will be shared, and the link to join the gala is on the bottom of the slide. So at CurePSP, we see our work falling under three pillars that is supporting our vision. Most importantly, for all of those that are suffering from these diseases is to find a cure. And to do so, we need to fund relevant research and establish the right partnership. And this is one of my primary responsibility here at CurePSP as the Vice President of Scientific Affairs. We also want to promote and advance care to help families, patients, and caregiver to have access to the best care that exists at this point. And then we also do a lot of work in sharing information to healthcare professionals that are part of the support system of a PSP patient and other prime of life brain disorder. And one of the very important aspects also is to promote consciousness and to create different partnerships and projects that share awareness of what are prime of life neurodegeneration and also what are the challenges in addressing them. So when I mentioned that one of my primary responsibility at CurePSP is to work and promote research, eventually to advance or the time that we need to develop a cure, I wanted to spend a little time with the audience here and thinking of, there are many ways to develop a cure. We have different ways to think of how to develop a cure, and the entire community is tackling all those ways at the same time. For instance, we can treat the symptoms. So in this case, we would want to address the symptoms that experience at different stages of the disease. We could try to develop a cure to address disease progression by blocking, reducing, or modifying the actual biological mechanisms that are involved in the disease. The ultimate goal and the most difficult to reach is to prevent the disease. So either to understand how the disease completely works and be able to block them, or to actually find particular changes in one's lifestyle that could decrease the chances of developing a disease. So one of my goal in this presentation and in this discussion that we're having is to showcase the complexity of what it takes to eventually advance the needle towards a cure. And as I will say, and then showcase in a few slides after this one, it really starts with developing the knowledge base of the disease. So how to really understand the science and how the science works. So basic research is really where everything starts, and it's one of the most difficult aspects of it, because we have to study biological mechanisms that are relevant to a disease outside of the human situation. So we have to find preclinical systems or experimental systems or models that as closely as possible replicate the science that we think is involved in the disease. There's also complex studies in epidemiology, for instance, to understand what is the diversity of the disease based on the environment, based on different population, based on the life history, etc. And more what you see in basic research is that the topics are prioritized by really trying to use the human situation as a focal point. And there's been a lot of work in developing measures, whether in the blood or other measures, brain imaging, for instance, to try to really characterize and describe how the disease is in the patient, and using that information to then prioritize the basic research. But the most complicated part, and Dr. Kerwin and I will talk a little bit about that, is how to connect the basic research to the reality of a patient that is going through this journey. And this feedback loop that I'm presenting in the middle here, it's that the basic research has to really be prioritized based on what's relevant to human. And it's a term that is used often, translational science, and this is what we're trying to promote at CurePSP, is to really try to help people focus, and scientists to focus on questions that are most relevant to patients. And another aspect, and Dr. Kerwin, we talk a little bit about that when she describes her work with the Centers of Care, is to also connect the progress of basic research towards the patient situation, but into the real context of how to deliver care. And there is an enormous amount of people that are really focusing on the second cycle here, connecting the work that makes it to patients and to a clinical trial, and we'll talk a little bit about that, into the actual practice of a medical situation. So when I mentioned the difficulty of this particular process, so I'm just going to go one slide back here. I mentioned connecting basic research and bedside. There's many of the aspects of this work depends on the development of complicated and costly and long-term clinical trial. So here I just wanted to have a schematic that describes in simple term, but shows the complexity of the path of a clinical trial. And I'd like Dr. Kerwin to just maybe give us a little walkthrough of this figure.
Sure. Thank you, Dr. Diaz, and thank you, everyone. It's a pleasure to be here. One thing about research that I think becomes frustrating is the understanding of the research process, and what Dr. Diaz was talking about, this translational science of, even though the steps can take a long time, the discovery that's made at each step in development actually feeds back into the scientific loop with more data and better understanding. Even a negative finding can help us get further along the road. And the one thing about PSP, CBD, and MSA that you should know is that they are considered rare diseases. So they fall under the Orphan Drug Act. So actually, the development of treatments for these diseases, the FDA actually will expedite or shorten because of the need for these diseases to have better treatment. But really, as Dr. Diaz was talking about, the journey is starting with basically an understanding of the biology of the disease, developing some sense of what target or where you could interfere in the path that will stop the pathology from occurring. So that all occurs in drug discovery and preclinical. And preclinical is actually looking at disease models. Sometimes that can be cell models. Sometimes those are animal models. Does this drug or this target really get to the target in that disease model that we can create in a different species before it goes into humans? And then the clinical trial phases, phase 1, 2, and 3, that's really where the human development piece is. And that's a place where participation in clinical trials can be very key. We learn a significant amount about drugs along the way. Sometimes we find that they don't work the way we'd like them to, or we find out that the safety may be of issue, but for the most part, that's the piece where we really learn about what is the right dose, the right patient, the right time frame to deliver the drug. And that's the information that companies and scientists need to bring to the FDA for approval. So although it seems like it's a long journey, it's a very, it feeds into the science for not only our understanding of that disease treatment, but oftentimes many others. And then after you get to phase 3 and you have your full complement of data showing that you believe that this agent works better than giving the patient nothing, and you have some type of endpoint, either a pathological endpoint, in this case showing a reduction in tau, or showing an improvement in function or quality of life, and you bring that data to the FDA, and that's what gets reviewed. And again, because these are rare diseases, they oftentimes do get expedited reviews, and also patient advocacy groups oftentimes will give input to the FDA as well, so that's where CurePSP would come in as well.
Thank you, Dr. Kerwin. So we'll have a couple more slides that give you more information on the different aspects, or phase 1, phase 2, phase 3. I think it's important for the community to share, to understand what each of those phases are really trying to achieve and to target. But before we do that, I want to go back to that pre-discovery phase, which, as I said, it's an important part of starting this pipeline. So as I mentioned before, basic science is really where it starts, and I just put three of the concepts that people are trying to really tackle in PSP research or CBD or any kind of research for a particular pathology that hasn't had a cure yet. First is how can we study human biology in the experimental system, and this is a huge conundrum for the community, and hundreds of people are working every day and trying to do that better. And what are the biological mechanisms relevant to a disease? And this is really the part of, can we just first understand the normal function of what we're trying to study, and then we can try to dissect what goes wrong and what is changing in that creates a disease. So it's really the background of the biological mechanisms that exist and what are the ones that go wrong. And once you've identified something that seems to go wrong, you can then start to understand how can we change or revert that change, and is reverting the change enough to eventually stop or slow down a disease. And so those are abstract concepts, but it's really the algorithm or the pipeline that scientists use in order to try to understand a particular aspect of the biology of the disease that can be addressed in a therapeutic setting. Just to give some very high level notion, and it's really, it's a good news in a way. The problem is far from being solved, but there are good news in terms of the consensus of the research community. So as many of you know, researchers have found a common mechanism to many brain diseases. And here I'm just giving you a schematic to remind everyone that the core cellular factor of the pathologies that we're trying to solve is that neurons in the brain, or brain cells, and you see them as schematic in yellow, are dying off faster in those diseases than in normal aging process. And I'm mentioning here that there's 100 billion neurons in the brains, and it's really, and giving you some ideas to represent that, what is 100 billion neuron. And if you think of a neuron being around 10 micrometer, and if you were to put them all next to each other, it would cover 62,000 miles. So I'm putting those numbers to kind of share the complexity of what's in the brain, and the fact that neurons are dying off. It's a good common mechanism to start to study and focus. And the entire community, and since the discovery, for instance, of tau protein in 1975, so a long time ago, is really trying to understand, why are neurons dying and how do we stop neurons from dying. So we have a common mechanism, a common concept, a cellular mechanism, and there's also, as many of you know, a common culprit, so to speak, to many brain diseases. So if you think from a cell and you focus at the protein level, so what's inside the cell and what gives the cell the function, it's been discovered for a long time now that different proteins, whether it's tau or beta amyloid or alpha-synuclein, start to behave in a way that is not normal. And this simple schematic show you that you have proteins that have normal functions. In this case, it's a blue protein. And for reasons that are more and more understood, the proteins start to change into a shape that gives it a pathological behavior, so to speak. And the core of this pathological behavior is that the proteins start to aggregate in a way that usually you don't find in normal cells. And this aggregation, understandably, creates havoc in the cell system that eventually leads the cell to death. And then, unfortunately, the system self-propagate, and this is why you have, such as in PSP, a fast progression of the disease, because this protein tau, in this case, start to aggregate more and more prominently in the brain. So the reason I'm mentioning we have a common concept and theme for research, and there's a common culprit, I want to bring hope to this conversation. And this is one slide that shows the investment in tau-related research since 2006 to 2016. So very recently, the field has accelerated, and you could see that the total funding in 2006 was 50 million, and now we're close to 400 million, or at least 3 or 4 years ago. So the field is recognizing that those approaches are the ones that are giving us hope to eventually be able to not only slow down the disease, but hopefully to cure it. So I just wanted to spend a few minutes showing you what CurePSP does to impact research. We are funded since 1997. We funded our first grant, and really scientists approach us with novel ideas and new approaches, and we get those ideas reviewed by an independent scientific advisory board that makes recommendation. And since 1997, we funded around $15 million in research. And right now, there are 10 projects going on that were funded since I arrived and joined CurePSP in January 2020. So I just wanted to give you a menu of some of the topics, and that's relevant to what I mentioned, that we have a core culprit and a common culprit and common mechanisms for this disease. We have a few topics, and I encourage you to visit our website and read more about the researcher we're funding. We're funding projects that are trying to better understand the connection between genetic factors and PSP. I think that's a critical question that a lot of patients and caregivers bring to our attention. What is the genetic underlying of PSP? We have also other projects to really bring novel and innovative techniques or data science approach to understand at the molecular level, what happens in PSP patients. We have a couple projects that are focusing on the core biology of tau. How is it different from a normal to a disease condition? And some exciting projects are starting to try to validate new therapeutic approaches and strategy. So I encourage you to visit the website. And I always like to bring the faces of those that are doing this work. We have a description of all those new PIs that are being funded this year, and we're looking forward to see how their work will advance our mission. I'm bringing back this schematic of the clinical trial that Dr. Kerwin described here to give you some information on where to look for information. And many of you know of clinicaltrials.gov, which is a website where all the clinical trial, past, present, and being planned are listed. And there are other websites like Center Watch that are trying to make this information a bit more user-friendly and helps patient navigate this portal. I want to make sure that I give enough information on the different clinical trial. I will go quickly through the slides, but the slides will be shared with everyone, and you can access the links to get more resources. But there's a lot of clinical trials, and often when PSP patients and caregivers reach out to me, they say if they Google PSP for clinical trial, they find many, but the question is, which are the ones that are actually trying to prevent the disease? And those are few, and we know that. There's a few companies that are pursuing them, and they're difficult. But there are many other clinical trials that are trying to either better understand the population that is affected by the disease, better understand some prevention or the description of the disease. So it's an interesting diversity, and there are many studies that are being done, but only a few at this point are trying to really focus on curing the disease. We went through quickly the different phases, and what I wanted to mention here is that as you go from phase 1 to phase 3, you increase the number of patients that are involved in the trial. And that makes sense that in the first trial, what you're really trying to do, in the first phase, what you're really trying to do is to make sure that what you're testing from an experimental system to a human situation is safe at the dosage that we think will be needed to affect the therapy. And so as you go in phase 2, now you know that the trial is safe. You want to then show that the actual hypothesis that was developed from a preclinical and experimental system is effective in trying to address the mechanism that we think will lead to a therapy. So you go from safety in phase 1 to efficacy, to effectiveness in phase 2. And then in phase 3, when you augment the number of people that are participating to a trial, you not only confirm that the method, the strategy is effective, that the science has been targeted is effective, but then you start to look at long-term side effect by looking at a larger population. And as we know, each person is different and the biology is different for each person. So those trials are really there to understand in the long term, in a greater population, how are we affecting the disease that we're targeting. I just listed a couple ongoing phases, a couple ongoing clinical trial, and the corresponding URL here for clinicaltrial.gov. I'm not going to go into the detail here. I'll point out that there's often in the news when we hear that a trial has failed, for instance, the Biogen trial for PSP has failed. Of course, this is a terrible news for the community, but I just want to point out that sometimes the trials continue for other diseases, and this gives hope because the mechanisms can be common. So even if they failed for a particular pathology and there are scientific reason why they failed, those trials still have hope and can carry on and bring more solution to the population. So I'm not going to go through those, but I encourage you, once you have the slide, to click on the link and see at what stages those trials are. Those trials are the ones that are trying to use an antibody to try to prevent tau from aggregating in the brain. There are other trials that are using small molecule to try to either confer resistance to nerve cells or to also prevent tau from misbehaving, so to speak. So the reason I'm pointing out the fact that even when a trial fails in PSP, it's really to show the interconnectedness that exists between the different brain diseases. And this is a slide that I took from the website, where you see that a lot of work that is done in progressive supranuclear palsy and cortical basal degeneration, even though it's a small population, the mechanisms that are listed here are often common to other diseases that affect a much greater population. So in this case, as we know, in some diseases, tau is involved in PSP, but tau is also at the center of many pathologies, including Alzheimer's. So there's an interconnectedness between the effort that we all do in this community, and one of our work at CurePSP is to make sure we connect with the other foundations that are focusing on this work. So I almost a couple more slides on I wanted to give a shout out to one of our board member and one of the one that has been with CurePSP from the longest time, Dr. Golby. He's done a tremendous amount of work in characterizing the disease. And the question that I get often from patients and caregivers is like, where do we find information that will help us to really have a conversation with a doctor that will give us an advantage and be proactive as we try to tackle this difficult journey? And this book that Dr. Golby put together is really aimed for clinician and medical professional, but it has a lot of information that will generate questions to patient and caregiver, but trying to answer the question will be a good progress in being proactive in your journey. And I recommend that if you can, that you have this book as you try to understand the different aspects of the disease. There is a list of ongoing method to manage a different feature of the disease, and so this could be helpful to understand, what is useful versus what is maybe just discussed in forums, but has not been validated by research. Another places that you can go, and this has been probably shared in the past, but this year we started a more thorough Ask the Doctor program, and a lot of patients and caregiver can go on and ask questions, and all the questions are being answered by Dr. Golby and other doctors that have now joined the conversation. And as you know, often people have the same questions and then they can get the answers there. So I'm going to pass the baton there to Dr. Kerwin, just mentioning that I focused a bit on what we do for CURE, and she'll tell you more about some of the programs that are relevant to disseminate care the right way and understand better care practices, and also bring consciousness to the community there. So Dr. Kerwin, let me know when you need me to push to the next slide, and I'll do that.
Great. Thank you so much, Dr. Diaz, and thank you. Welcome, everyone. I hope through these challenging times, everyone's able to stay well. It's especially challenging for the patients and families that are dealing with degenerative diseases. So I'm really glad that we're able to come together in this way and still carry on our conferences and shared ideas and information. So I'm here because I'm actually really fortunate to be a part of the CurePSP Centers of Care. I'm actually a geriatrician, but I've practiced in neurologic diseases for many years and became, had several patients with PSP and CBD and other movement-based disorders. And when I moved to Texas, had the fortunate ability to be able to collaborate with several different centers around the North Texas area. So for that reason, we actually were again put in for a center of care, just from what we had learned about caring for patients with PSP, that oftentimes the delayed diagnosis, finding the right care, finding the right physicians, finding the right groups can be very difficult for patients. So our center really focuses on collaborating with all of the different resources that are available in the community that I'll talk a bit about. So you can go to the next slide. So this is the map on the right is actually where all of the current CurePSP Centers of Care are located. And so as I said, my center is in the Dallas, so North Texas area. And as I said, we're very fortunate to have several excellent academic centers, several really good movement disorder specialists, community care support groups, a lot of advocacy as well. But the mission of the Centers of Care, again, is take the research that's going on, but really what happens when the patient and the family goes home. When you're on your own with these diseases, it can be very challenging. So creating more of a care network that they know they can go to for resources, and the best way to find the best regional care that they can really help to improve quality of life, can help reduce the incidence of safety issues, and can help patients and families manage when oftentimes they're looking around and feel like they're the only ones that are dealing with this disease. If you have a regional center that you can tap into, you can find that there is many more patients that are dealing with it, start to develop the resources that you need to be able to care for, to deal with the disease on a daily basis. So again, the mission on the left is regarding the centers of care are there to find the best possible care, increase awareness of PSP and CBD. That's a really important concept. Well, oftentimes in my diagnosis, or when I do have a patient that is referred to our center, we find that their journey to getting the diagnosis is often prolonged because they often are searching for the right physician who can understand and recognize the spectrum of presentation that these diseases can have, and to really get down to the right diagnosis. Having the correct diagnosis is really important, not only scientifically from our science development, but for that patient and family to really understand what they are dealing with, what they can expect, and how to plan for it. So really finding the right healthcare professionals is really important. And then also there's other resources for physicians themselves. I know that many times we are very, as Dr. Diaz just spoke to about the clinical trial development process and how treatments are developed. Oftentimes there's treatments that are put out there as a potential cure, or maybe the cure, or which is a bit of an overstatement, but we really need to be careful about what is evidence-based medicine and what is not. And so providing resources for physicians even to understand where the current science is, what really has evidence behind it to use as a treatment to either treat the symptoms or the disease itself, is really an important concept. And I know Dr. Diaz and I have talked before about the concept of stem cells. So stem cells are a very important aspect of our development of a treatment, but there are sometimes clinics out there that are selling stem cells as a treatment or a cure for PSP and CBD, and really having the communities aware of where the science is, what really constitutes an evidence-based medicine treatment, what really is the data or the supporting information of, is this really going to work? Because the desperation to have better treatments can sometimes lead to sometimes harmful measures. And I will say that there's been some patients that have gone into a stem cell clinic that they thought they were getting stem cells and they're not, but just getting that therapy, even though it didn't provide them any benefit, it can actually sometimes preclude them from participating in truly developed scientific clinical trials. So providing resources to our local community physicians about what really is evidence behind there for treatments, things like Dr. Golby's book of where he really walks through what are the best treatments for symptoms, for function, having that available is really important for our center as well. And then the last part is promoting collaboration between centers. And this is where we're really lucky. Again, the North Texas area has phenomenal academic research centers. My center is actually an independent research center. We do predominantly clinical trials. We have had clinical trials in PSP and MSA, but we really collaborate with our local movement disorders neurologists. We collaborate with our, I'll go through the network of what we have in the North Texas area, but this collaboration and a hub for patients to go to, that even if we're not directly providing the care, we're giving them the list of names of the movement specialists or the centers that they can go to get the resources that they need for their day-to-day care of PSP and CBD. Go to the next slide. So I apologize for the small font, but it's the good news. So the map is the same on the right, but the list on the left is all of the centers of care throughout the United States for CurePSP. So you can see there's several academic centers throughout, mostly on the coast, and then we've got, again, several in Florida. But again, all of these centers are coming together and oftentimes are working on many of the multi-center clinical trials that are in development. They're oftentimes data sharing through CurePSP and other consortiums and collaborations. And so this is really helping to push the science, but also provide the care that's needed for the patients that are dealing with the disease today.
And I'll just add one more point to that network, that we are working hard if we're in the coming year to expand the network, not only to cover some of the area that might not be as covered, but also to think of ways to expand more internationally, whether in Canada or abroad. So we're working hard in creating even more collaboration between the different centers and more avenue for people to share what they're doing, so we can all learn from each other.
And that is a really important piece. So I put this up because this is really the basis for the care system or the care network. From a medical standpoint, as a practicing physician, oftentimes, diseases that a doctor is treating, let's take something like diabetes. Oftentimes they really follow one marker. They follow their glucose levels, maybe hemoglobin A1C, and they know that if they don't control those glucose levels, that there could be other organs and systems affected. It's very different for PSP and cortical basal syndrome and MSA from a neurologic standpoint, that oftentimes these diseases present with multiple neurologic findings at one time that progress at different rates. And so it really requires a holistic approach, because not only can there sometimes be cognitive changes in thinking, and oftentimes there's differences, there's changes in expression of speech and language and fluency. There can be difficulty with slowness of thinking. There can be movement difficulties. So things that arise from a safety aspect, such as functioning and in the home, being able to perform your activities of daily living, and falls that can bring a safety issue, are very challenging, not only for the patient and the family, but for the physician to be able to address all of the symptoms that might be presenting and follow them. So that's why having a multi-spoked network of care and using as many resources in the community as possible can be very helpful. So again, this is just some examples of what we know are some of the potential symptoms. Not everyone presents with all of these symptoms. Some patients present with one prominent symptom that really defines their disease for them. So it's important to know that it's still a very individual basis about how things present. But this is how, if you look at the aggregate of the disease, when we look across like observational studies and we do a natural history of the disease, these are things that can arise in some patients. And so again, being able to identify these, being able to identify that this is part of the syndrome, and then how to address it to try to at least maintain function, slow down the progression, or even sometimes, or use medications to treat these symptoms is very important. So again, the research that's been done and then presented, such as in Dr. Golby's book and other papers that are published, about how do you assess the severity of the disease, and then how do you track the patient. And so that's where, again, rating scales are often used to track the different areas of, are you having difficulty with your speech? Are you having difficulty with your activities of daily living? If you're having tremor, what is the extent or severity of the tremor? And using a rating system so that the doctor can really track the disease over time and know that if they institute a treatment, some medication or physical therapy, they can really track that rating scale to see, is this making an effect or a benefit in holding the progression? And so that's where this holistic approach is really important. And how do we, first of all, identify the symptoms, rate the symptoms for their severity so we can track them, and then address them and usually the priority is address them in areas that will help to slow down the progression, preserve function and safety. And safety is really a key area of this, especially with PSP and CBD, is the fall and some of the motor symptoms can actually put the patient who could have very good functioning. Otherwise, if they have a fall with an injury, a fracture, or something like that, it can really cause a rapid decline in their condition. And so doing everything we can to address all of those particular symptoms is important. We can go to the next slide. So one of the things that I know we have in North Texas, we have associations with several really excellent physical therapy departments, home health departments, community centers that have exercise programs. And we actually have some specific exercise programs that are meant for people with atypical Parkinsonism, in which PSP and CBD often falls under. And so really maintaining that function and safety is important. As I said, for the patient that has a fall with an injury, we really don't want to have that be a setback for them. So addressing these with a interdisciplinary approach is important. So usually this includes aerobic exercise, transfer and balance training, again, to prevent falls, gait training, learning how to use assistive devices effectively, such as weighted walkers, to prevent backwards falls, which can commonly happen with PSP and CBD. Flexibility training, which we don't think of as often, we often think of strength training, but flexibility training can actually help you prevent a fall as well by just being more agile as you are moving about. Using intensive routines, goal-oriented tasks, like going through a training program of how to perform your activities of daily living safely so that you don't increase your risk of an injury. Oftentimes vision can be a presenting symptom for PSP, especially, and sometimes CBD. And so that's where there are some exercises for visual tracking. A good ophthalmologist oftentimes can fit with prism lenses that can help to train gaze to help reduce some of the diplopia or double vision that can occur. And then there are motor cognitive exercises. And one thing I'll say about the COVID challenges now is that oftentimes these group exercise classes that were happening had to dissolve because of the COVID risk. And so patients really were more isolated and having more difficulty getting to these exercise classes. And so the one thing I will say is we've moved a lot of our resources to what's available online that you can basically sign into from your home, safely do the exercise classes there. And also that's being done also for speech therapy. We have a lot of speech therapists that are doing basically telehealth speech therapy sessions, and as well as motor cognitive exercises. So there are a lot of web-based approaches that you can do, exercises to help improve cognitive flexibility and mental flexibility that can be helpful to slow the progression as well. We can go to the next slide.
Oh, yes.
Okay. So this is, on the right is just a diagram of, basically all of the potential agencies, resources that come into play in taking care of a patient with PSP or CBD. And it probably is not even exhaustive. There could be many more in there, but what we've found is, at least in the resources that we've identified in the North Texas area to help our patients, is really finding good primary care doctors that if they don't know about PSP and CBD, we can provide them information about what it is, and so that they can increase their awareness and understanding of the disease. And that's important because even though they may not be the primary treating physician, they're still providing vaccines and treatments for hypertension and other things, and they do need to understand some of what the disease that the patient will be dealing with. Movement neurologists are really some of our key resources, and as I said, we're really fortunate that we've been able to identify quite a few. Some of them have a really excellent understanding, and some of the others we ask that they, we try to provide the resources from the CurePSP Centers of Care for them to even improve sometimes their understanding of what are the current therapies, the clinical trials, what approach should be taken. Radiology centers are important. Good neuroradiologists that know how to read some of the dopamine scans that can help to identify sometimes the differentiation of, is it really, when oftentimes patients come in with this diagnosis of Parkinson's or Parkinsonism, but sometimes a good neuroradiologist who knows how to read the MRI and the DAT scan can help to differentiate, to say, this isn't just an atypical Parkinson's, this actually looks much more like PSP or MSA or a CBD pattern. And so that can be helpful for the physicians that are treating the patient to feel more confident in their diagnosis. As I said, speech therapy and physical therapy are really key. We really look for speech therapists who really understand what exactly is the language challenges or speech challenges so they can try to work with the patients to improve speech. We do have, as I said, speech therapists that have gone to telehealth sessions where they can do speech therapy actually by video, and physical therapy as well. A really good optometrist, ophthalmologist that understands the vision challenges of PSP and CBD, that understands how to use prism glasses and tracking, and some can oftentimes provide sometimes a therapy lesson for that is really important. We've located several medical equipment suppliers in our area where we know that they carry some of the equipment that's really specific to this area, such as a weighted walker. Oftentimes I've had patients come in with a standard walker that they get at Walgreens or whatever, and that's not incorrect, but it's too light, and oftentimes if they're falling backwards, that walker is not, it's actually sometimes impeding their movement or making it somewhat increased risk of falling backwards. So we really try to get them to the right equipment suppliers. A good dentist that understands the disease as well and can accommodate some of the movement changes that occur is important. A pharmacist that can be helpful in describing sometimes what some of the medications can and can't do and how to take them appropriately, especially something like Cinemet that some patients are on, and they sometimes are taking it 3, 4, 5 times a day and different dosing titration regimens. It's important to be able to have a resource to tap into. And then sometimes, because there are sleep issues, a sleep specialist who also would be able to diagnose and treat and understand what can occur with sleep. Go to the next slide.
Yeah, I'll just have a quick comment on that. What fascinates me with this particular approach is to really underscore the value and the potential impact of a center of care, even though there's only, let's say, one in Texas, based on the work that Dr. Kerwin is describing in our map. But each center can really make an effort to connect with the correct medical support system that needs to be put in place for a rare or uncommon disease, and increases the likelihood that a patient will be recognized and taken care of quickly. So I think this is a great example of what we need to pursue and to carry on in the Center of Care initiative.
Go to the next slide. Yeah, and one thing I have found is that even if there's, the dietitian or the speech therapist is not a specialist or with PSP, they oftentimes, when they have a patient presented to them that says, we really need you to help us with our care plan, they are willing to learn about it and really try to develop the best and most focused and tailored care plan for that patient. So the other part of our resource for North Texas is really a lot of the patient support groups that are available. We have atypical Parkinson's support groups at the hospital. We have something in Richardson, Texas called the Parkinson's Voice Project that just happened to be in our backyard that we collaborate with extensively, and they provide really great resources, as well as there's many Facebook patient groups that I find that the Facebook patient groups for PSP and CBD really stay on top of what research is going on across the country. When a new clinical trial starts to become available, they oftentimes are in communication with each other about where is it occurring, what centers have this study, and they oftentimes are getting to those centers to be able to participate. The patient advocacy organizations like CurePSP, AFTD, and the Alzheimer's Association can also, although Alzheimer's Association is not specific to PSP, they do want to serve all dementias, and so they do try to provide resources there as well. And then there's research networks. And again, this evidence-based medicine is really important for patients that are looking for a cure, really going to what is really the evidence-based, really good scientific methods that are occurring. So there's things like the ARTFUL group that I'll talk about in a minute, clinicaltrials.gov that Dr. Diaz already brought up, which is a great resource. You can find out what trials are going on. Trial Matches, an Alzheimer's Association resource. NeuroNext is actually a National Institute of Health, or NINDS, supported network of neurological centers that are performing neuro research, oftentimes in rare disorders. So they're trying to increase the network so that they can get enough patients in to be able to do a multi-center clinical trial. And then there is pharmaceutical industry as well that is interested in developing therapies in this area. Go to the next slide.
Yeah, I just wanted to give you a time check. We should wrap up in the next minute so we can have time to get questions.
That sounds great. This is just ARTFUL, is the Advancing Research for Treatment in Frontal Temporal Lobe Degeneration, which is one of those studies that's doing observational, understanding the biomarkers of all the different FTDs, which PSP and CBD would fall into. Dr. Adam Boxer at UCSF is the PI on that, as well as Brad Beauvais at Mayo. And go to the next slide. And then also part of this consortium is my actually introduction to CurePSP was through the Tau Consortium, which I had the honor of taking care of, Mr. Rainwater. And the Tau Consortium is, again, one of those collaborative research groups that really it pushes the science, pushes the funding, wants to work with CurePSP and other advocacy groups, and really tries to make sure that the data sharing is there for the scientists to remove some of the competitive issues so that really the science is pushed for the good of the patient, which we're all here for. You can go to the next slide. And this is just actually my final slide, so we can move on to our Q&A session. Again, if there anybody would like to reach our center, if anyone's in the Texas area, we're here as a resource for you. And again, just my pleasure to be here with you all today. Thank you. We can go into our questions now.
Thank you, Dr. Kerwin. And I'll just mention that in the slide, there's also my email here. And if there's any questions, please feel free to reach out directly. So if there are any questions, we'll be more than happy to have a conversation to try to address them.
Mm-hmm.
Terrific. Thank you guys so much. This is Jacqueline Zendrian, Vice President of Events, coming into you like the voice of God.
Hi, Jacqueline.
So, hi. All right. So we've got a couple of questions that have come in so far. First one that has come in is, on average, what is the time in terms of years between the brain changes in cellular level and the clinical presentation in a given patient?
Yes, Chris, would you like
Yeah,
to?
I mean, it's I guess we could have a conversation around that, because that's one of the difficult part of developing a therapy is like in different neurodegenerative disorder, it's found that sometimes the rate of neural loss has to be really high before you can see, you can detect something with the normal measure, let's say a family member or a primary care physician. And there's a big discrepancy of that, and that's a big problem, because if you detect it too late, even if you had a therapy, maybe there will have been too much neural loss in order to really revert it. And so there's a lot of work now in science to try to detect by using blood measure or more precise measure signs that we're starting to lose brain cells. So the brain is a very complex and redundant system, so it's resilient. You can lose a lot of brain cells before having a particular detectable effect. So that's great in a way for being resilient in the aging process, but it's becoming a challenge. I don't know if Dr. Kerwin, if you want to add some comments to that.
Yeah, thank you, Dr. Diaz. So that is one of the reasons why these diseases are very challenging, at least even the diagnostic, is the fact that by the time symptoms do occur, oftentimes the pathology has been occurring in the brain tissue for a few years. It's probably at least 2 to 5 years before symptoms develop. As Dr. Diaz noted, you have to have degeneration in the brain cells before your brain's going to actually not be able to compensate, and you're going to notice a symptom, either speech or motor, that presents first. And that is one of the challenges for physicians as well, and why oftentimes the diagnosis is missed. We really need to have some type of blood-based biomarker, or even a CSF biomarker, that we can start to detect the changes in the brain tissue before the symptoms actually occur. And that's where, research in diagnostics, although we're all looking for a treatment, that diagnostic piece is going to be very important, because when we do have the treatments, we're going to want to give it as early as possible. So having some type of diagnostic biomarker to say you have early changes, you don't have symptoms yet, but here's a treatment, that's really the goal. So it definitely, the question's great. There's definitely several years that the brain changes occur before symptoms actually present clinically for diagnosis.
Thank you so much. So another question is, based on the slide you showed with 3 phases of drug discovery, it looks like the minimum amount of time it would take to create an approved drug would be 10 years. Is that accurate?
That is about right. It's actually sometimes even longer when you start from really the bench side to the treatment being actually approved. And part of it is, again, having to go through that drug discovery and then really identifying, is it the target? Is it really addressing the target? And then having those animal models before we go into humans. And then in the human studies, I mean, a phase 1 trial itself can oftentimes take several years, sometimes 2 to 3 years. Even though they're small, it oftentimes is only 20 patients. It's still just getting the patients in, analyzing the data, and then going to the next phase. Just that phase 1, 2, and 3 period can actually take quite a bit of time, just because we need to really know, is it better than giving somebody nothing? Is it really safe? Is it effective? How effective is it? Is it worth us, putting it into the drug regimen? Because there oftentimes is also an economic impact there as well of expense.
Yeah, I'll just add one comment to that, is that the regulatory framework that is trying to make sure that everything happens in a way that respects the patient's safety and interest is also recognized that in some cases things to be accelerated. And Dr. Kerwin mentioned that for some diseases that are not as common, there's been evolution in the past few years to try to accelerate some of the processes. So if patients want to be able to have access to some more experimental yet validated therapy, they can at least apply to participate. So everybody is trying what they can to accelerate the process, but it's a very complicated one that does unfortunately take time.
Yeah.
Great, thank you. So how does the protein evolve across a 5 to 7 year journey of PSP? What happens in years 1 to 3 versus 4 to 5 versus 6 to 7, for example? And is there any learning on slowing down that progression or symptoms in any way based on learning to date?
I'll take a first stab at that. So it's a great question, because it really connects what I mentioned, the main culprit of the protein that accumulates, right? And it's a dynamic process where it starts to accumulate in a way that at first is not detectable by the method we have. So there's some brain imaging, for instance, that a patient can be injected with a particular molecule that goes to the brain, that binds to that culprit, tau in this case, and using some advanced and complex imaging technique, you can image that protein in the brain. But in order to image it, unfortunately, the protein has to already have reached a certain concentration. So if you think of what happened before in the process, in the first years of it, it might not be enough to be able to detect, right? So it's a linear process where the proteins start to aggregate first in one brain region. And what's been seen now is that the spread of this protein and this accumulation start to spread in all the brain regions. And I would say that the difference in in tauopathies, in the diseases that are connected to the accumulation of tau, is often seen by the different brain regions that are affected first, or in the sequence of what brain region is affected. So there is a known progression, and there is some work in Alzheimer that I've been in Parkinson that established the fundamental of that concept. So we can detect it, and we can see that it grows over time, and that is also correlated with a decay in functions like cognitive function. So this is why the community is excited to go after this particular target, because we really hope it can slow down pathology. But at this point, there's still no real solution for patients. But it seems to be the major hope there.
Yeah, I agree with that. And I would just add on, so with the tau protein, it is, and we all have tau protein. Actually, tau protein is a normal part of the cellular structure of the neuron. It's the abnormal folding, actually, or twisting of the tau that occurs inside the cell. So it's intracellular initially. And so we get the accumulation of this abnormal tau protein. So that's the accumulation, and then it aggregates. And then you get what's called propagation, where it starts to move neuron to neuron. We're not quite sure the mechanism. So that's really why the treatments can be very challenging. So the treatments are, do you target first the abnormality that occurs in the tau? Do you target the accumulation, or do you target the propagation or the movement throughout to other areas of the brain that start to develop more neurodegeneration and the symptoms? And so that's where oftentimes that scientific discovery that Dr. Diaz was talking about, understanding the underlying biologic mechanism. Why do some people develop PSP or CBD? Why does the tau start to have this abnormal formation? Why does it accumulate and propagate? How can we block it at all those different aspects? And that's where we oftentimes may have more than one or two different types of therapies that are developing at any one time, which which is great, and oftentimes may end up being, in the end, what our treatment, effective treatments are, might be more than one medication. But it's a great question, and something that the scientific community, that's really why that basic science research is so important.
And I should add that if you think of an advanced part of the disease, so later years where you have a lot of tau, people are trying to understand what type of treatment at this stage could be useful to patient. But the holy grail is really to understand a very, very early mechanism that start to trigger the normal protein, and it's an important point that Dr. Kerwin mentioned. Tau is part of our normal function. And what are the earliest events that are going wrong, and how do we target those? And that's the holy grail, and it's the most difficult one to access, because it's just a few tau proteins start to misbehave, so to speak, and then it's hard to detect because there's so little of them. So it's a bit of a catch-22, but it's a great question and a recognized problem and challenge in the field.
Thank you. What progress is being made in correlating brain autopsy, a destructive test, with non-destructive tests such as CAT scans, blood work, MRIs, etc.?
Sure. So I can address that. So that was, I had talked about the ARTFUL study, and what Dr. Diaz talked about the importance of these biomarker studies. So ARTFUL, and actually there's another called LEFTIES, which is looking at also the genetics. But the ARTFUL study and these observational biomarker studies are looking at bringing in many, many patients with these frontal lobe diseases like PSP and CBD, and correlating what's in their spinal fluid, their blood, their genetic makeup, their clinical presentation, brain imaging, PET scans, really pushing the development of better imaging. So the imaging that we do have available clinically is either CT, or more often we use MRI. And the MRI really helps us to look at the anatomy, or basically the atrophy pattern or the shrinkage pattern in the brain that can oftentimes give us the diagnosis. In PSP, it's oftentimes midbrain atrophy that we see. In CBD, it's actually in the cortical basal regions. But also going the next step now is a specialized type of CAT scan or CT scan, which is called a PET scan, where there's ligands, which are markers of tau protein, abnormal tau protein, that are given in the bloodstream. They go up to the brain, bind the tau protein, and then you can take a CAT scan and identify where the tau is being deposited, how much tau is present in the brain tissue. And so there is a lot of research that's been done on that in different neuroimaging centers around the country. But it is really important as a diagnostic to do something that's less invasive, like a brain imaging scan, versus, as you said, we really don't wait until time of death to give the diagnosis. We really want to be able to give the clinical diagnosis, have good biomarkers like imaging, blood-based or spinal fluid-based biomarkers, to really be able to be very accurate in our diagnosis.
Yeah, and I should say this is an unfortunate reality that at this point we still require this neuropathology exam to really confirm the diagnosis. But the community has made tremendous effort in developing, even very recently, those techniques that Dr. Kerwin mentioned, to be able to image tau in a more precise way in the early stage of the disease. So a lot of people are working hard on that. So it's a great question.
Thank you so much. So one last question that we have time for, and this one was pre-submitted during the registration process. Dr. Golby has mentioned in several of the YouTube PSP videos that liquid CoQ10 is useful. Can you recommend a specific brand of CoQ10, and is there a specific dosage that's helpful?
I can, but not right now. So I know in this, what I can do, I can add one slide in the book that I recommended. There is a chapter on that, and then how Dr. Golby actually prescribed it to his patient. He does it in a way that you want to make sure that you don't just do something to do it. You want to be in connection with the patient, and then you want to see if it works or if it has any kind of positive outcome. So I know when he does prescribe it, he connects back with the patient to see if it makes any change, and if it doesn't, then he no longer prescribes it. But I do have that information on the top of my head, but it's in that book, and I'll add it to the slide and share it back with you, Jacqueline, or others, so you can you know, send it to all of those that are participating to the conference. But I know it's one of the rare over-the-counter supplement that has been tested in a clinical trial and that shows some sort of positive effect because it protects parts of the cell that usually are decaying fast in neurodegeneration. So to be continued, but it is interesting. Go ahead, Dr. Kerwin.
Just one comment I want to make. I know Dr. Diaz will get you the specific information, but I just want to commend you on that question for many reasons. One is that supplements in the United States are not regulated. So when they are on over the counter, they really are not vetted by the FDA. And you do really want to be sure to discuss that with your physician so that you do know that there's evidence-based medicine of which brand you should use and what dosage and everything. So I just want to say across the board for any of the treatments when they are over the counter, having that discussion with your doctor, asking those questions about what's the right brand, the right dose is exactly the way to approach it. I just want to say, please keep doing that just because there are some caveats to us that people are trying to sell things off the shelves and we have to be smart consumers. So I just want to underscore that. So thank you.
And thank you both so much for being here. We really appreciate all of your insight and advice today. And for those of us who are on the East Coast, we're headed into lunch. For those of you on the West Coast, you're headed into a coffee break. And please join us again shortly. Thank you.
Thank you.
Thank you, everyone. Pleasure to be